Shall we start? Yeah. I'm Michelle Liu from Ferring as the regional medical head in reproductive medicine and maternal health. Welcome everyone to join today's Sicog Ferring Symposium session, physically or virtually. So I hope you enjoyed these sessions, interaction, discussion, or some knowledge, some information refreshed. Now it's my honor to introduce the chairperson for today's session, Professor Tim Dracott. I think everyone know him. Professor Dracott is currently a consultant at the North Bristol NHS Trust. And over the past 15 years, he has led the development of a completely new academic department in ONG in North Bristol that is now recognized as the world-leading intrapartum and safety research center. He jointly developed the prompt obstetric training program, which prepared unit-level staff to improve their management of intrapartum emergency and has been associated with the significant improvement in clinical outcomes. So his work has been recognized by prize from NHS Innovations. And in 2014, he and the prompt team was awarded the Queen's Anniversary, the International Prize for Resilience in Healthcare in 2016. Now let's give the warmest welcome to Professor Tim Dracott to have the opening address. Professor Dracott, the stage is yours. Welcome. Yeah.
Thank you very much, and thank you, Michelle, for hosting this and bringing everyone together to talk about. I think one of the biggest challenges of maternity care in the next decade. How do we personalize care? How do we personalize care for fetal medicine? How do we personalize care intrapartum? How do we personalize care antenatally? And I think, delighted, that's me. I'm going to introduce T.Y. Lung is going to speak. I was going to do my little slides, but don't worry. So I'm going to introduce T.Y. Lung to speak on PPH, and then Shapali is going to speak on induction of labor. But I think the key thing for us is, rather than you just listen to us kind of tell you what we think about the data, I think one of the real opportunities of this, and there are 300 people online in a hybrid meeting, but one of the things we'd really, I think, value was all your experience and your expertise. How do we kind of personalize care in a standardized system? And I made a joke to EK and Engloy earlier on. Maybe that's what private practice is. You're personalizing care, you've got continuity, everything else. But I think we're going to listen to both the talks, then we're going to have a few little tiny questions we can answer. And then I really would like people online and everyone in the audience to kind of share what they would do for PPH prevention and induction of labor. So let me just quickly introduce TY, who is much more famous than me in this area. Professor in the Department of ONG at Chinese University of Hong Kong, and now Assistant Dean, I think, for the Faculty of Medicine. TY's list of interests I always find embarrassingly long. I do a bit of intrapartum care. TY does intrapartum care and fetal medicine and genetics and a lot of other things. Published more than 300 papers in impressive high-impact journals, and been running the Asian Pacific Congress in Maternal Fetal Medicine since 2005, and multiple training courses, particularly around this region. So TY, really looking forward to you speaking on PPH prevention. Thank you.
Let me show my slide first. Oh, this is my slides? Yeah. Something different. Okay. Okay. Now, so we all know that oxytocin is a very useful drug. Oxy means very quick. Toco is contraction. So the beauty of it is very rapid onset. And indeed, this is a natural hormones, but was synthesized in 1953, and the inventor won the Nobel Prize because of this. It saved a lot of maternal life. And later on, we have this capitosins with some modifications of the bondings of the chemical structures. And because of this, it is more resistant to enzymatic degradation, and therefore it have not only have a rapid onset, but also have a longer duration of action. And now it's also very heat stable and do not need a refrigerator for storage. And it has the same affinity as oxytocin to the receptors, and therefore is more effective in preventing PPH. So capitosins is almost the perfect drug for prophylaxis of PPH because of rapid onset, longer durations, highest efficacies, and minimal side effect, except that the cost is the highest. While syntocinolones have the limitation of short duration, cytometrines have the limitation of more adverse side effect, and misoprostol is the cheapest, but then the efficacy is the lowest. So if we can sort out the cost problem, then capitosine will be the ideal drugs. Now in 2019, WHO recommended the use of capitosins is recommended for the prevention of PPH for all births in the context that there is its cost is comparable to other effective ultrasonics. Now here, WHO say all births. That means not only cesarean section, but also vaginal delivery. Not only high risk, but also low risk. So you may wonder how these expensive drugs can be applicable to all births, right? But the cost is comparable with others. Now, these are the cost-effective analysis published before 2020, and most of them have shown that capitosine is cost-saving or cost-effective for cesarean section. But how about vaginal birth? How about low-risk vaginal birth, right? Or is it still cost-effective when it is used in the combination of vaginal birth and cesarean section, or even in vaginal birth alone? Now, that is our questions. Now, so to understand cost effectiveness, you know to know the methods. And most of these studies are retrospective, using the data from the cost data from the local institution or local countries, and then we assume this decision tree, and in different pathways, what are the possibility and how much will be the cost. Now, it will be very complicated for you to understand, for me to understand too, right? But after reading all this, I try to guide you to understand with a simplified models like this. Let's say to start with 1,000 pregnant women, and after birth, all are given oxytocin. And the cost of the oxytocin is just $1. Right? So the cost for this is $1 times 1,000, so $1,000. And let's say majority do not have PPH, and subsequent management have low cost, right? For us to calculate, make it simple, low cost. And some of them, let's say 10% will have PPH, and the cost of the management of PPH is $100. Right? That means 1,000 times 10% times $100 is $10,000, and therefore the total cost is $11,000. Very simple, right? And then we can also say cost per birth is divided the amount divided by 1,000, so it's 1.1 per $. Okay, now this is the simplest model for you to understand to start with, and then if the risk of PPH is variable, let's say now X%, X is 20%, then it's 21,000 totally. 30% then becomes 31,000 totally. Now, so go back to your secondary school mathematics. You will find that total amount is Y. This fixed amount is A, right? And this management fee is B. And the variables is H. X, that is the risk of PPH, incidence of PPH. So Y is equals to A plus BX. And then you can draw this line, right? Now, so this line is the total cost in relation to the incidence of PPH after oxytocin. And if this is a cohort of C10 section, then the risk of incidence of PPH is 30%, 0.3 or 0.4, even more, right? And if this is vaginal birth, this is 0.1, okay, 1%, 10%, right? And you know how we compare with that of carbidocin. If the cost of carbidocin is 10 times more, but then the risk of PPH is reduced by half, okay? Now, then we can draw a line like this, right? That means if the background risk of PPH is less than 20%, oxytocin will be more cost effective, right, or cheaper. If the overall risk is more than 20%, then carbidocin, right, for all people, right, will be cheaper or more cost effective. Okay? Now, so this is the simplest model. Now, but of course, there will be variation. Let's say, in some situation, the cost of carbidocin is 20 times more. Okay, then you will see the line shift up, all right? But it's still parallel because the risk of PPH is the same, right? Reduced by half. But if the risk of PPH is just reduced by 30%, that means it is 0.7, right? Then the starting point is still US dollar 10. But then the gradient will change, right? And therefore, you will see that the intercept will be now at 0.3. So you need a higher overall incidence of PPH before you can find that carbidocin will become more cost effective, right? Now, so this is the variables. Another variable will be the management of PPH. Previously, I give you an example. $100, which is 10 times of carbidocin. But how about if it is 20 times more expensive than the use of carbidocin? Then both of the line will shift up like this. Okay. Now, then you will see that the intercept. There's some change in this position. Originally, it's 20%. Right? Now it's about here, something here. So if the cost of the management of PPH becomes higher and higher, then you will find carbidocin will be more cost effective, even with a lower incidence of PPH. All right? Now, so these are the variables. One, how much expensive carbidocin when compared to oxytocin. Second, the baseline risk of PPH with oxytocin. That will depend on the section weight, priority, maternal age, etc. Thirdly, how effective is carbidocin in reducing PPH, right? 0.5 or 0.7 or so on. And lastly, is the cost of management of PPH. That includes salary, transfusion, surgery, hospital stay, and so on. Right? Now, having this in mind, I go through these 4 papers with you, all published after 2020. Now, the first one is in Canada, second one is UK, third one is Hong Kong, and the last one is published from India. And they have different costs, right, because of different localities. And you can see here, oxytocin to carbidocin, carbidocin oxytocin ratio, right? Canada is 7.6, UK 21, and Hong Kong 10. That depends on the cost of the local cost of oxytocin and carbidocin, right? Now, in a previous simplest model, I used 10 times and 20 times, right? You know the lines, right? Now, in India, you'll be surprised that it's only $0.24 and $0.38 for oxytocin and carbetocin, right? The reason is there's a special price in India, right? For some reason, right? And therefore, the ratio is only 1.6, right? Now, there are many costs for the management of PPH. I just list the hospital stay to you, right? There are many, right? It's very complicated, but I just list the hospital stay as a reference. And this is very high in Canada and UK, nearly 900 US dollars, and Hong Kong, 600 US dollars. In India, it's very low, around 60 US dollars. Now, in this Indian paper, they actually divide into primary, secondary, and tertiary centers. And different centers, the cost will be different, right? But I give you a median as a reference, right? But because the carbetocin is very, very cheap there, and therefore hospital stay to carbetocin is 160 times. Now, in the previous example, I just showed you about 10 times or 20 times, right? But here you can see that usually it is more than 20, sometimes 40 times. But it's only hospital stay cost. I haven't put into salary and so on, right? And therefore you can imagine the cost of the management of PPH, right, is not on the carbetocin. It's just a minute portion, right? So if you can prevent PPH with carbetocin, you can save a lot from the cost of the management of PPH, right? So vaginal birth, Canada 70%, UK's paper, all of them are vaginal birth, they exclude cesarean section. Hong Kong around 10%, Indian 85%. And then the range of PPH, oxytocin, carbetocin, so it's 0.5, 0.7, 0.7, 0.7, all right? So I also use 0.7 in my simplest model as an illustration. And for cesarean section, right, similar, 0.5 to 0.7, all right? Now, based on these figures, all of them found that using carbetocin for all birth, it saves the money, right? This is about 97 US dollars per birth saving. In Canada, 68.29, in the UK and in Hong Kong. And even in India, it's 1.7 saving. So different models, different settings, right, will have different results, right? But I show you the major variables to you, right? No matter how these variables are different in different settings, they're still saving money with carbetocin. Right now, so sometimes you may want to save more, and you may have a questions. How about just use carbetocin for high-risk group, right? And then use oxytocin in low-risk group. Will it be more cost-effective, right? Right? Of course, right? If you have this meticulous stratification of risk, theoretically you can save more money. But even without this, right? Carbetocin alone for all pregnancies already saving money. You want to save a bit more, right? But theoretically, yes, but logistically it will be more difficult, right? You may have a little gain, but the meticulous stratification may introduce a lot of inconvenience, right? Administrative costs and so on, and these are all invisible costs, right? So I would say a single regime for all is a, right? If you show that this cost in your hospital or in your country. Now, another question is, if I use carbetocin for all women, what can I do if PPH occurs afterwards? What else can I use? Right? What drugs can I use? Now, of course, you may have to rule out other causes of PPH, like retinal placenta or lower genital tract, that carbetocin would not help you. And sometimes some women will not be responsible or responsive to carbetocin. right? For example, after prolonged labor and so on, and some are of unknown reason that we don't know, right? And in this case, you may try a bolus of syntocinon, but I think you may also need to consider to use either ultrasonic or mechanical methods. And especially in case of the situation that PPH has occurred, right? That means the mother is losing blood, the drugs is inside the circulation, and you're also losing the drugs, right? And you may not be able to maintain a therapeutic level. You may also transfuse fluid and dilute the drugs level. The mother is hypotensive and may have a reduction in the uterine perfusion, and therefore have a limitation in the drug delivery to the uterus, and that makes your medications less effective. And pharmacodynamically, when the mother is in hypotension or in shock, the tissue, pH, calcium, and will be low, and you may reduce the effectiveness of the contractions. And therefore, in such situation, you may have to consider mechanical methods to stop the bleeding, right? Like external compressions or intrauterine balloon, right? The uterus is refractive to drug stimulation, and therefore you need mechanical method, right, to reduce the blood loss first, and meanwhile stabilize the circulation, and then the uterus will then become responsive to the drugs again. Now, this is the main concept of the resuscitation. Now, and therefore, when you read the RCOG guidelines published in 2016, and you can see that here you need you can give a lot of drugs like oxytocin, augmentin, oxytocin transfusions, or 8 doses of carbobox, right? So, will you give so many times before you will consider mechanical method, right? I would recommend you, right, that if there is already blood loss of 1,000 or 1,500, that the mothers have hypotensions, I think about the intrauterine balloon first, right, instead of continues to give multiple doses of drugs, right? Because as I mentioned, pharmacokinetically, pharmacodynamically, the drugs will be less effective, right? You need to support the circulation. You need to reduce the blood loss first, right, by mechanical method before the drugs become effective again. Now, okay, so let me conclude here. Now, carbidocin has a longer half-life and make it more effective than oxytocin in preventing PPH. Although carbidocin is more expensive than oxytocin, its cost is still relatively cheaper than compared to that of the management of PPH. And therefore, prophylactic carbidocin is shown to be more cost-effective in different settings, right? In the management of PPH than for prophylactic oxytocin. But when PPH still occur after carbidocin's prophylaxis, then think about other means, right, to reduce the blood loss. Thank you very much.
TY, thank you very much. I think a fantastic example of what's the difference between cost and value. And I think it demonstrated the value. So what we're going to do, TY, is Shapali is going to speak next, and then we're going to do some quick questions, and then I thought we could then talk about this with the audience. Would that be okay? Thank you for a great talk. So I'd like to introduce Shapali Tagore, who clearly is well known to this audience in particular. Consultant, senior consultant at KK. And director, are you still director of the International Medical Program? Yeah, fantastic. Maybe I could join that. So graduated in India, came to KK, did her obstetric critical care at Duke's in Durham as well, but now actively involved in teaching, training and research, and director of the International Program doing obstetric emergency stuff, which we've done together, and special interests, cervical incompetence, placenta accreta, fetal heart rate monitoring and induction of labor. Shapali, thanks very much.
Yeah, I think I just. Okay, good evening, everyone, and thank you very much, Tim, for the kind introduction, and thanks to Ferring for the kind invite as well. I'm very delighted to be here today, and today I'm going to talk to you on induction of labor, whether there is need for standardization. So induction of labor is a common intervention in pregnancy, and rates of induction have been rising steadily, almost doubled in last decade, and 1 in 4 women are induced in developed countries. And this has been attributed to both patient and physician factors. Most of the major guidelines, they recommend induction for clear medical indication so that the expected benefits outweigh the potential harms. And induction of labor is not without complications. In fact, there are serious complications such as uterine rupture, hyperstimulation, fetal compromise, and sometimes even amniotic fluid embolism. So the medical legal issues as well, which involve failure to recognize the hyperstimulation or failure to give tocolytics. Also, women's preferences and perception of induction of labor should be taken into account. They should be informed of all the risks and options and plan for failed induction. So what are the key influence factors? Well, key influence factors, gestational age, Bishop's score is an important predictor, parity, and of course method of induction. And the success of induction of labor depends upon the cervical ripening and uterine contractions. Higher the resistance offered by cervix and pelvic floor, more is the work needed by the myometrium. So in this study, you will see that in nulliparous women with a poor activity required is 4 times that of a multiparous woman with a good score. So let's look at some of the challenges of induction. So the first is when to induce. Well, there are risks with early induction of labor, and delivery before 39 weeks without medical indication is associated with worse perinatal outcomes, and not only RDS but increased rates of NICU admission, cognitive as well as IQ problems. The timing of delivery is not only dependent on the indication but also the severity of the indication. And recently, induction of labor has been recommended at 39 weeks to optimize fetal and maternal outcomes. But of course, there are concerns of logistics, cost, and failed induction of labor. Well, this is a meta-analysis which looked at the effect of elective induction of labor at 39 weeks on the risk of cesarean section and on maternal and perinatal outcomes. And you can see elective induction of labor was associated with reduced risk of cesarean section, and even associated with reduction in perinatal deaths at or beyond 37 weeks and fewer NICU admissions. Well, when there is a medical indication, the potential benefit for the mother or the fetus outweighs the induction of labor risk. And these are some of the common indications for induction of labor. Well, even if the medical indication is elective indication without, not for medical indication on patient request, still favorable cervical and obstetric conditions should be a prerequisite to decrease adverse effects in elective inductions. Well, there are several pharmacological, mechanical methods of induction. In KK Hospital, we use Cervidil, prostaglandin tablets, and a balloon. So this is a network meta-analysis for induction of labor, and naturally each of the different mechanical or pharmacological induction method has a different mechanism of action as well as safety and adverse effect profile. And no method showed superiority on all three outcomes: vaginal delivery within 24 hours, hyperstimulation, and avoidance of cesarean section. So vaginal misoprostol was associated with the highest incidence of uterine hyperstimulation, Foley's catheter less as compared to other methods, and oral misoprostol was associated with avoidance of cesarean section. So prostaglandins are the gold standard, and they can be administered as a gel, tablet, or as a control release pessily, like Cervidil. This study looked at labor outcomes with a comparison of Cervidil with tablets, and they found that the cervical ripening, full dilatation, and delivery time was reduced by 5 hours in the Cervidil group as compared to the tablets. And these are some of the the comparison with Cervidil. It's a single insert, so it has very high patient acceptability, and even it's convenient for the healthcare staff. There was reduced need for the use of additional oxytocin, interventions to stop hyperstimulation, and even rates of instrumental deliveries. And there was also reduced time from induction to delivery and oxytocin augmentation as compared to the balloon. So we compared Cervidil with Cervidil and membrane sweeping. Earlier studies compared Cervidil with other methods, and we know that sweep is associated with favorable labor outcomes. So in our study, both induction methods were equally effective in term of achieving vaginal delivery within 24 hours. But in 6%, in DVI with sweep group, they required additional methods as compared to 11.5% with DVI only group. What about mechanical methods? Mechanical methods are low in cost, they are easy for storage, and also they require less stringent monitoring of uterine contractions. We compared the progesterone PGE2 tablets with mechanical method like cervical ripening balloon, and we found that there was no difference in the pain score at the start of induction of labor, but thereafter the pain scores were lower in the CRB group. Both were equally satisfied with both methods, and they were most likely to recommend their methods. What about Cervidil with double balloon? Again, in the Cervidil group, the rate of vaginal delivery less than 48 hours was higher as compared to the balloon. And these are some of the other maternal outcomes for Cervidil versus double balloon. Induction of labor with misoprostol, there's high rates of hyperstimulation, and we do not use misoprostol for induction of labor except for IUFD, and that is also suggested by the NICE guidelines in UK. Then the next is where to induce the setting of induction. Well, it could be outpatient as well as inpatient. So in KK hospital, we do not do outpatient induction. In the outpatient setting, induction of labor should only be carried out if safety and support procedures are in place. And of course, there should be regular audits as well. Well, KK hospital, ours is a high-risk pregnancy referral center with 11 to 12,000 deliveries. We have 30% cesarean section rate and about 28% induction of labor rate. So we tried to standardize our service for induction of labor. Well, we know that we have large heterogeneity and variation in the practices in our unit, and the induction practices also significantly vary among the providers. So initially we used to carry out our induction in triage areas, and the nurses had to handle the admission, clerking, medication monitoring every 4 hours in addition to the patient load in the triage. And during bed crisis, this group of elective patients were not given the priority, which led to long waiting time inconvenience to patients with occupied triage beds. So this is a paper who it looked at the standardization of service as well. And the objective of this study was to evaluate the impact of induction of labor protocol on reducing maternal and neonatal morbidity. And they found that women in the labor protocol group had a shorter time to delivery, decrease in the maternal morbidity, and lower rates of neonatal NICU admission with lower neonatal morbidity. So we had a multidisciplinary staff engagement from various stakeholders, and we made changes to our clinical pathway. We streamlined the work process with efficient allocation of resources, which would actually minimize the patient movement, which would optimize beds in triage with reduced operational cost, and of course enhance the patient safety. And then we also took this opportunity to introduce Cervidil in our unit. So this was the standardized protocol for Cervidil and PGE2 tablets and the cervical ripening balloon. So it led to synchronized timings, and we also had definitions for failed induction of labor and where to induce, which patients would go to the labor ward and which patients would go to the dedicated induction of labor unit. So this is after the implementation of service. So the patient, we had a positive feedback from patients, and the triage waiting time reduced from 18 minutes to about 7 minutes. And this is the Cervidil after the implementation. And our time duration of between 2 prostine tablets reduced from 10 hours to about 6 hours. So in summary, induction of labor is rising. At term, it improves the outcomes. Of course, induction of labor is associated with risks. It should, the medical indication, the preferences of each woman, cervical status, method of induction of labor should be considered, and perhaps standardization would help. Thank you very much.
Brilliant, Shapali, thank you very much. And I think we certainly have a standardized induction of labor suite to get people through quickly. So what I thought we could do is a few little tiny questions. Now, we haven't got enough facilities. You're going to have to put your hands up in the room, but the online, you're laughing at me already, but the online people are going to vote. So I thought, why don't we just quickly go through? So if the online people, you've got 20 seconds to vote, and in the room, you've got 20 seconds to have a think about. So after TY's talk, which is a bit easy now, I think, but in your current practice, do you use, and you can only choose one of these, do you use carbetocin for all sections, some sections, or no sections? So if we go start voting now online, and I'm going to say, right, in the room, who uses carbetocin for all sections? Okay, so let's say 25%, 30%. Who uses carbetocin for some sections? John, come on, we're going to talk about this in a minute. Okay. Who uses carbetocin for no sections? Just use oxytocin. Okay, most people didn't vote. Okay, so most people, of the people who voted, okay. So can we have the results from the hybrid meeting? Okay, similar to this really. 14% none. So we use, I'm going to say now, we use carbetocin. Now, it seems to me from your work, TY, the more often you use carbetocin, the more money you save. Maybe, yeah, wow. That seems like a bargain to me. Okay, next, can we go back to the slides? Thank you. Okay, second one, who uses carbetocin for all vaginal births, some vaginal births, no vaginal births? So if we can just go vote now online. Okay, who uses carbetocin in the room for all vaginal births? Really? Okay, that's good. IV or IM? IV. I think IV. I think definitely IV. Who uses it for some vaginal births? Okay. Do you choose high risk? Yeah. Okay. I see. There's some wise people at the back. I can see who are, who is being careful with their money. And who uses for no vaginal births? Me. I'm with you, John. I mean, we don't. We did the study. We did the IMOC study. We still don't use it. Okay. Online. What's the results? Okay, so similar to the room. Similar to the room. Interesting. How do you define a high-risk birth that you would use carbetocin for? Assisted vaginal birth? Well, you don't do those in private practice. So how would you choose who to give it for vaginally? I don't know. See, I think it's difficult. I don't know. Anyway, okay, that's great. Let's go to the next one. Now we're going to do induction of labour. We've got 3 questions for induction of labour. Oh, God, no one wants to look at me, particularly myself. Okay, thank you very much for taking that off. Thank you very much. So you've got a 34-year-old primate. That would be young by our current service. 41 plus 3, low-risk pregnancy, Bishop score 3. Would you use a single balloon, double balloon, misoprostol, prostaglandin tablets, or Propes, Cervidil Propes? Okay, so online, start voting. Thank you. Okay, in the room, who'd use a balloon? That's interesting, because John, my understanding of your paper was women don't like having a balloon put in, but once it's in, they kind of prefer it in some ways. Who uses a double balloon, an extra expensive balloon? Yeah, so we use it after a prostate, total waste of time. Double balloon, no more effective than a Foley. Anyway, who would use misoprostol for a completely standard primate? No one. Wow, 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 wow. In the States, that'd be absolute routine. We could talk about that. Who would use prostin tablets or pessaries, standard? Yeah, one, few. That's not Cervidil, just standard prostin, yeah? Okay, so there's a few here at the back there. That's because you're old school at the back. That's you've got to catch up with the 21st century. And Propes, who would use Propes? Okay, that's a real spread. Okay, that's a real spread right across. So no one really balloons, no misoprostol. Okay, so a spread between those two. Okay, online, what's the answer? Similar to here, I think. A few people, yeah. I mean, and these people, Michelle, these people are all of Asia. This is not just ASEAN, this is Asia. Yeah, okay, interesting. Okay, next one, thanks. Okay, exactly the same woman, but, oh, no, exactly the same woman, but now rupture membrane is 24 hours. Okay, for the private practitioners in the room, this is not an indication for cesarean section. Just want to hashtag just saying, as my 22-year-old tells me. Okay, who would use a balloon for this? Okay, vote. Start voting at the back, thank you. Who would use a balloon? I don't think, not for rupture membranes. No? No one's using balloon. Double balloon? Okay, who would use Synto? Straight out. Yeah, okay. TY, you definitely would. Yeah, okay, Synto straight out. My problem with Synto straight out is it takes a long time to get into labour, and we haven't got space on labour ward to look after them. That's my issue with Synto. Anyway, misoprostol. Anyone use misoprostol? No. Prostaglandin pessaries tablets. Yeah, same people who use it for the first time. And Propes. Same people who use it the first time. Okay, interesting. Okay, online. Okay, so Synto leaping forward. I mean, you said on births. We only got 12 labour rooms. We've got to get people do. Okay, next, last one. Okay, exactly the same woman, but now previous section. Okay. 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 Pretend to do a balloon. Cesarean section. Yeah. I think, yeah, good option. Okay, but she's already gone past 40 weeks. She's chosen she wants a VBAC. Now, that definitely happens in some settings. I know, not many, I know that. Okay, so previous section. Okay, vote online. Thank you. Okay, who would use a balloon for this?
Recording in progress.
We can have a little discussion about that. Yeah, because that sounds like hard work to me. Prostaglandin pessaries or tablets? Yeah, okay. People who would use that anyway. Propess? Definitely, we would use either balloon or propess, same as TY. Okay, so one of the things we were talking about. And this is, Oh, online result. Sorry, Michelle. Thank you very much. Online result for the last one. It's coming. Okay, balloon, double balloon. Are some people in this room secretly voting online? Because this seems remarkably like this room, I think. So again, a mixture, but clearly a swing towards balloons. I think there's a sense, isn't there, that balloons are less risky. What's it? 25, 2.5% rupture rate if you use prostaglandins, 1% if you don't. Okay, so thank you very much. Thank you very much online. Thank you very much, everyone in the room. Now we've just got a few minutes. Honestly, take me off. I can't bear it. Honestly, thank you very much. God, my children would just die thinking I was on TV. So one of the things I thought we could get out of the room was just to have a think about what people do in the room differently. And clearly there's a big spread. So let's say carbetocin, we're talking about personalization of care. And I think we do have to personalize care. I think there's some really excellent opportunities to personalize care, particularly for placental dysfunction, for suspected preterm labor, for many other things. And I think there's some really excellent tools to do that. But it feels to me that there's a benefit of standardization it's just simpler for the service. So at what point do we say, now, in our service, we would use carbetocin routinely for all sections. Just makes life easier. And now in the NHS, we're too mean to use it for vaginal births at the moment, but I'm going to go home, TY, and tell them we could save money by, it's like a bit like when my daughters go shopping, they tell me that they're saving money by spending money. I never really understand that as a concept, but yeah, I'm going to come back to you, but I think for cesarean sections now, but my problem is, how do we personalize care at vaginal birth and choose who to give carbetocin for? Or if you look at Deirdre Murphy's study, I don't know if anyone saw it, from Dublin, if you use IV syntocinon at vaginal births, you halve the transfusion rate and halve the PPH rate compared to IM syntocinon. And I think those of you, we're talking about using it at vaginal birth, I think IV is that's why IV, all the section data is very positive about carbetocin because it's IV, and all the IM data is less positive about carbetocin because it's IM. And I think that's the same as syntocinon. But how do you choose who to give carbetocin to? No offers? Just in case I'm really mean? Okay. Yeah? Yeah. I mean, in our service, yeah. I mean, that seems absolutely sensible to me. In our service, if you're induced, you're much more likely to have a PPH. If you have an assisted vaginal birth, you're definitely more likely to have a PPH. And I just think, you know, can we, and I know Ben Moll in Monash is making a tool for risk for PPH. So we might be able to say, right, okay, at this threshold of risk, you're probably going to have a cannula in anyway, just give carbetocin, you know, at that point. But I don't think we have those tools yet. So, okay. Induction of labor. Anyone got any top tips on induction of labor? Yeah. Yeah. Yeah.
Why is the rate of PPH so low in Hong Kong compared to the other countries?
I think you'll find it's good care, John.
Yeah, thank you very much. Now, certainly, these are all retrospective study, and this all depends on the clinical estimation of fetal blood loss. This is collective data from all public hospitals, right? So there's the fact that I can show you, right? Whether this is better care in Hong Kong, that the reduction of the or low incidence of PPH, or actually we underestimate it, right? Difficult to tell, right? But certainly the incidence of severe PPH, right, that require blood transfusions or advanced surgical interventions, right? I think it's about 0.5% to 1%. Yeah.
I mean, certainly in the IMOX data, Chinese ethnicity women had a lower rate of PPH than the background rate for Caucasian UK women. Now, we had very few, so it's not a massive, but I think it's 0.7, 0.78 as an odds ratio if you're Chinese, so maybe that makes a difference too. But yeah. But if you look at PPH rates across the world, I mean, who here weighs blood loss after birth? Or does everyone just estimate it? Okay, I'm going to say to you, definitely weigh it. I'll tell the story. Who's coming to the Sicog meeting the next couple of days? Most people? Okay, I won't tell you my story because you're going to hear it at the talk. But yeah, weighing definitely is a probably useful thing. But so some people estimate it. If you weigh it, you double your chance of PPH because we underestimate by 50% every time. So it depends very much how people are reporting their PPH rates, I think, John. Any other questions for T? We've only actually got a few minutes left. Any other questions for TY or Shapali? Yeah.
I'm trained in the period where if I induce a patient, all the senior doctors, professors will frown and say, why? Is there a medical indication? But recently I've been told that it is medical legally important to offer a suitable woman at term, expecting management and induction of labor. Is this becoming a medical legal issue?
Well, okay, that's a really important question, and a question for our time, because in our service, our induction rate is 34%, 35%. And our problem now is how do you accommodate all those women being induced? That's a real issue for us. But I mean, if you say to women, so if you look at the Cochrane Review, and Shapali, you talked about this, the Cochrane Review says we can't hide these data from women anymore. That's actually what the Cochrane Review says. So option A, do this. Option B, I'll double your section rate. I'll double your induction, your chance of going to NICU, double your chance of baby being born with a low APGAR, but I'll slightly increase your instrumental rate. That's expectant management. Option B, I'll halve your instrumental rate, I'll halve your section rate, halve your NICU rate, halve your low APGAR rate, and slightly increase your instrumental rate. That's induction. So the idea is, now you're a young man, I know that, but you know, when I was young in the 90s, you were told if you induced, that was a cascade of intervention. And that was a terrible thing to do, and you were harming women by inducing them. But that's completely changed. But I think the future of this is, and we're doing some work on it at the moment in the UK, and there are many units at TY or uses, the Fetal Medicine Foundation, Placental Dysfunction app, the algorithm. I'm sure you do, John. I'm sure plenty of people do. But we're making an app of Kipros's placental dysfunction algorithm, so women can use it and staff can use it right across the UK. Because if you're placental dysfunction positive but got a normally growing baby, you definitely should be induced at 39 weeks. If you're placental dysfunction negative with a normally growing baby, then I think you've got a choice at 39 weeks. And that's my point about how do we start to personalize care? Because at the moment we treat, I don't know about here, but we treat all 39-year-olds the same. Doesn't matter if you're 39, 2 normal kids, and you're a county netball player, or you're 39, first baby, BMI 50, IVF, we treat you exactly the same because you're 39. So I think this is where we've got to start getting into personalization in a slightly more
Recording in
and value.
progress.
Now, just to tell you a story, I once bought my wife a handbag from Primark for Christmas. And everyone's laughing at me because I thought this is good value. My children still remember that Christmas. It was not a happy Christmas. Okay, Shipali.
I think I just want to comment on the question. About not just the induction, but I think the timing of induction would be important as well. Like what you have asked. I mean, it's whether it's going to be medical legal. Yes, if the induction is at 37 weeks, that without any
Disaster.
proper medical indication, then yes, it is a medical issue. As compared to if you do not offer induction to somebody who has impending macrosomia. So I think it's important when we are talking about induction, it's important to kind of triage patients into risk or high risk pregnancy, and then take a personalized decision.
Sure.
Thank you.
I mean, if someone had a stillbirth at 40 weeks and they weren't offered induction at 39, I think you'd be discussing that. Now, if they were completely normal at 40 weeks, there's no discussion. Let's be clear. But I think you have to at least document a discussion. I think so, that's a good point. Let me just say about 37 weeks. I'm just going to summarize. But okay, what we mustn't do is induce at 38 and then 37 and then a bit before 37. For each week, you go down less than 39 weeks. You increase the risk of behavioral difficulties and you increase the risk of poor performance at school. And in my clinic, when women come in, and I'm famous as a real pushover in clinic, I'll induce most people, but someone comes in and goes, "Oh, Tim, I'm 36 weeks, my pelvis hurts, this hurts, everything hurts. Just induce me." And the mother goes, "Yeah, it really hurts, so come on, just induce her." I go, no, because it's your transit, just click that, sorry. And it said, no, don't do that, because the outcomes are worse. It's transient tackling a newborn. They go, yeah, that's fine, just induce me. And I now tell everyone, Donald Trump was born at 36 weeks, which is true, which is absolutely true. And every single woman goes, "I'll see you next week."
I can see what behavioural difficulties at late preterm birth look like, yeah. So look, thank you very much, everyone, for coming today. It's been fantastic. Thank you very much, Michelle and Eileen from Ferring, who've organised it. And it's absolutely lovely to see you all. Thank you very much.